International Day for Celebrating Women. I'm very pleased that, this webinar is actually spanning the entire globe, so to say. We have a speaker from USA, and we have panelists right across the Asia Pacific region from Australia to Turkey. So a very good and fantastic representation. And I'm delighted that, this is probably one of the few rare Women's Day events where we have active, rather proactive and very encouraging support from the leadership of APOA and Dr. Onder Eidingers and Dr. Arif Khan, who are on the presidential line as well as the chief of the secretariat, are here to encourage us and welcome us. Welcome, Onder, and welcome, Dr. Arif Khan. May I request both of you to give us a few words of encouragement before I introduce our lead speaker, Dr. Arianna Gianakos.
Thank you, Zita. Happy Women's Day to you all. I'm sorry, there is a reconstruction in the building. I don't know how it affects my sound, but I'm very happy that we have waves in APOA. I hope we will have more women colleagues in the APOA in the near future. I was the chair of APOA Education Committee, and we conducted a survey on education and training in APOA countries in 2022. And one of the questions was about the percentage of women orthopedic surgeons and also residents in APOA region. Actually, it was changing from a country to other, but the APOA average was 4.7 for the orthopedic surgeons and 8.8 for the residents. So we will have more women in APOA in the near future. If women and men are not equally represented in any profession, that profession is missing half of the best. And men and women are equally capable. And without women, we are left with men who are less good than women, actually. So we need women in every profession. And I hope we will have more in orthopedic surgery in the near future.
Thank you. Thank you. Very, very nice and kind words, Onder. And we promise that there will be more. Definitely times will change. Dr. Arif, who's the Secretary General of APOA, can we have a short word of introduction, and encouragement from you too?
Thank you, Rajuta, Prof. Sara, hi, and thank you everyone for having us here. It's wonderful to see everyone today here. It's a great day, and it's always very like an excellent occasion to be amongst the leadership of the WAVE section and the women in the society and in the orthopedic community as a whole. So as Onder said, it's our wish, and we are trying our best to include more and more women in the orthopedic community. And your role in bringing more women is very crucial. So just like playing a role model, when people see you in the leadership role, more and more girls are trying to come to the orthopedic community, and it's always good to have them more. So thank you very much for having us here, and thank you for having such a wonderful webinar today. Thank you.
Thank you. Thank you. We really appreciate this warm gesture from the APOA Exco and the leadership. And we are missing our dear President Jamal, who's always been a champion of women's rights and has been, at the forefront really of the diversity. But I think he's busy with the AO course today, and I'm sure his best wishes are with us in spirit. So coming to the most awaited thing of today, it's my pleasure, privilege, and actually a very, very heartwarming, opportunity to be introducing Dr. Gianakos. Dr. Arianna Gianakos is an attending orthopedic surgeon and assistant professor at the Yale School of Medicine in Orthopedics and Rehabilitation. She completed her foot and ankle orthopedic surgery fellowship at the Harvard, Massachusetts General Hospital in Boston, Following her fellowship training, she became the first and only international in-office needle arthroscopy and sports medicine fellow in the world at NYU Langone Health, training with leading foot and ankle sports medicine surgeons in New York City. London, Amsterdam, and Bologna, some of the other training centers that she followed, and worked with elite football players, soccer players, ballet dancers, basketball players, martial artists, and whatnot. Dr. Gianakos has also been working towards completion of a PhD, so which means she's going to be a double doctor with the University of Amsterdam, with her area of focus on gender differences in foot and ankle orthopedic surgery. Dr. Gianakos is one of the founding members of Speak Up Ortho, which began as a social media campaign created to raise awareness on the prevalence of abusive behaviors in the field of orthopedic surgery, particularly during training, a truth that some of us don't really like to encounter and address. But it was a very brave initiative on her part that the group developed into a platform that provides safe environments for both men and women who experience hostile workplace conflicts. She's also a board member of the Physician Just Equity Physician, providing volunteer peer support to physicians and surgeons in the United States who experience workplace conflicts through education, research, empowerment, and advocacy, while facilitating institutional culture change that optimizes patient care. In 2022, she was awarded the Women in Medicine Summit Trailblazer Award, and in 2021, she was awarded the first ever Ruth Jackson Orthopedic Society Courage Award for her work. She has over 50 peer-reviewed publications and 10 book chapters and has presented her work at numerous national and international platforms across the world. She's a passionate mentor, serving as a leader and an educator. And besides being stunning, I think Arianna is beautiful, because beautiful from inside is what defines her, with the 3 C's that I will attribute to her. That is courage, clarity, and commitment. The stage is yours, Arianna. Take it away.
Wow. Thank you so much for those kind words. That was a very, very humbling introduction. And it's a true honor to be here amongst some incredible peers and this great panel that you put together. So I'm truly honored to be part of this event. And it's amazing that we are able to come together as women in this event and speak about some maybe not so comfortable topics. But I think that means that we're making great progress so that the people following in our footsteps have an easier way than maybe, the people who went before me and my level, and we all want to pay it forward. So it is a true honor to be here. So I'll get started. I'm going to be talking about dealing with abuse in the workplace, how we can go from a bystander to an upstander, and provide some strategies, and how we can be an ally and advocate for other women in medicine. These are my disclosures related to this talk. And so I want to first just start off with a scenario example, and some of the scenarios throughout this talk and some other situations are all taken from our Speak Up Ortho platform. So these are all real stories that people have submitted in. So Dr. Helen Hand is a 38-year-old hand surgeon. She rounds in the morning in the hospital with her team, which is comprised of 2 male residents, 1 female medical student, and 1 male medical student. As she walks into the patient room with the group, a 45-year-old male patient turns to the 2 male residents, inquiring about his care. Dr. Helen Hand introduces the team members to the patient and introduces herself again as the primary surgeon. The patient responds to her, "You're a good-looking girl. Are you married? Definitely too young to be my surgeon." And I wanted to start with this, and we will revisit some of these scenarios and how to attack this and how to, combat this and what we can do for ourselves and for others when we're in the situation. But you can see that it's common for sometimes men, especially male patients and even female patients, to assume that the man in the room is the doctor, whereas the woman might not be. In addition, there are some areas where patients, sometimes it's just unintentional, but can say things that are a bit inappropriate that can make you feel uncomfortable. So we're going to talk through some of these things a little later in the discussion. But let's talk a little bit about how do we define the word abuse or hostile work environment, or what are some things that we may encounter when we're in residency and training years, or even as attending surgeons and consultant surgeons. So bullying discrimination, sexual harassment, and microaggressions tend to be the more negative behaviors that we focus on, and they are widely reported in the field of medicine, not just within orthopedics, although in orthopedics, it's reported at high rates. And this is not just in the US, that we're finding that this is global. The consequences of these behaviors, though, can negatively impact the physician's well-being and mental health. It can negatively impact a trainee or a physician's productivity. And then ultimately, this leads to poor patient care and poorer patient outcomes. So let's first define these behaviors a little bit more. So what is a microaggression? Well, this is typically a comment or some sort of action that's unintentionally and also unconsciously often expressing some sort of prejudiced attitude or a negative attitude. And often these attitudes are towards a marginalized group. So it could be a racial minority. It could be, if you're in a group of men, it could be towards the woman. It's towards a group of individuals, but it can also happen to anybody. What's bullying? So there's no legal definition of bullying, but this is repeated, unwanted actions. It can be physical, it can be verbal. And the biggest thing is that there's an intent to harm in this case. So intimidation, harassment, degrading. Oftentimes, this happens when there is a power dynamic between a senior person and a junior person, and there's an abuse of that power. It has also been termed as a way of psychological violence, actually. Discrimination is a way where someone might be treating someone differently, and this is typically in a less favorable manner. And harassment is more of this evolution of discrimination where these behaviors turn into something very negative. There's offensive conduct, it's repeated, and ultimately the goal of the harassment is to intimidate and create this hostile work environment. Sexual harassment can be any form that includes requests for sexual favors, offensive comments, or even physical sexual behaviors. So what are some of the things that we can do about this if we are encountering this in our workplace, or if we're seeing someone who is enduring these types of behaviors? Well, in 2021, a group of orthopedic surgeons who were like-minded, all female surgeons, banded together because we wanted to raise awareness to address that these behaviors were more prevalent and also weren't even spoken about. I have a lot of male colleagues who are incredible allies to me. And when I told them some of the stories from my own personal experience and those of my colleagues, they were baffled. They were appalled. They couldn't believe that this was still going on in this day and age. And if they knew that, they would have said something to help and speak up about it. So we wanted to raise awareness. So the goal of Speak Up Ortho originally was to encourage people to have that strength and ability to come forward and speak up about harassment, bullying, abuse, marginalization in the orthopedic field. So this was our mission statement when we started back in 2021. We were created to allow anonymous sharing of experiences. Our mission was to give a voice to those affected by those abusive behaviors so that patients and colleagues, and whether it was a surgeon or a resident or a medical student or even a representative, anybody in the working place, felt that they had a safe space for listening and support. And we felt that this was the first way that if we acknowledge that these behaviors exist, we can raise awareness, and that is the first way that we can actually start moving the needle to make the work environment better for our colleagues and ourselves. Within the first 2 months of us going on our platforms, which initially included Instagram, Facebook, and Twitter, or X, there was over 375 submitted stories, all anonymous, some people having their name associated with it, but within 2 months, almost 400 stories were submitted, and they ranged from bullying, harassment, sexual harassment, discrimination, and even retaliation when people did try to stand up for themselves, the negative impact that they had on them in their lives. We initially had only had this represented in the US, and then it ended up expanding virally over the globe. And then it also ended up expanding into various subspecialties. So it really demonstrated that this was not a specific US only problem, where US only in orthopedics, but it was actually also a worldwide phenomenon that was going on that spanned across various different surgical specialties as well. So we have these narratives, and these are some that I wanted to pull. They are true stories that were submitted to our Speak Up Ortho platform, and I've only pulled a handful just to give you an example of some things that we were receiving. When I was a medical student, I was sexually assaulted by a fellow. The school ruled that nothing happened and sent me to mandatory therapy, and I was told to find another specialty. He, the perpetrator, had no professional consequences. As a program director, I always made sure to protect my residents from abusive behaviors. Even as a leader in my program, my own chairman bullied me and created a toxic environment. I experienced bullying and retaliation so bad that I actually spent time working in a closet or hidden in the back of a friend's office. One night, when it was time to come home, I ran into my house, forgetting to shut the car off in my enclosed garage because I was so mentally drained. I could have killed my entire family. So you could see a medical student was affected, even a senior person who was a program director. And this is one last one. I became unexpectedly pregnant and told my fellow residents. One of my uppers made comments about the group picking up my slack while on maternity leave, ending with the statement, "I will bring a wire hanger to work tomorrow. You know what to do." So you can see that these are things that are experienced at various different levels and stages around the globe, and they're serious and they're destructive, and they can ultimately lead to a dropout rate and attrition where our physicians may not want to continue their training because of their hostile work environment. So our goal initially was to raise awareness, and we were welcomed on podcasts, news outlets, and this was throughout all different subspecialties in our orthopedic field. We also published on some of our work. We looked both at the training level and how there were high levels and high rates of all of these behaviors. Survey studies also demonstrating high numbers of women in particular voicing that this was something they experienced, but men too experience some of these behaviors too. So it's not just limited to women alone, although women tend to be a target of this, unfortunately. But we also published on ways that we can provide solutions and how to handle this. Some of the action items we wanted to start with were implementing intervention training, which we'll go over in a little bit, code of conduct, both within hospital institutions as well as within residency programs, and then also within societies themselves. A way to vet for leaders, because a lot of times people don't even know that this is going on with maybe someone who is in their society. Educating people on the concerns of what has been going on and what needs to still change, different ways of reporting, and also creating safe ways of reporting. So having a resident advocate when it's a resident student level, having a third party professional or someone else to serve as someone who can mediate some of the situations, and then having overseeing bodies that are objective in nature. In addition to Speak Up Ortho, Physician and Just Equity was a group that was somewhat developed simultaneously and completely apart from Speak Up Ortho, and it's something I'm now part of. But it is a group of individuals. They are typically made up of physicians, but there's also lawyers who are involved. They do not provide legal counseling in any manner, but we provide what's called peer support. And essentially, if someone is going through a challenging situation or a conflict of some sort that they're not quite sure how to manage on their own, or they don't feel like they have someone they can turn to, they can log in and submit a request, and they can meet with a couple of people on a Zoom call who can help walk them through their situation and provide that peer support. Sometimes it's just being a lending hand. Sometimes it's just listening to someone who is going through something so they don't feel alone in it. And sometimes it is helping them provide solutions so they A, don't lose their job, B, maybe they have a better way of navigating a situation and then finding the right resources for them. So how can we be a peer supporter and an ally? So what is allyship? So this is anyone who can actively promote and advance culture of inclusion through positive change and through positive conscious efforts that are ultimately going to benefit that person who's in need, but also benefit the culture as a whole. I really liked this figure that was the quote anatomy of an ally. So we can use our mouths to speak against injustice, nose to sniff out bias, eyes to identify privilege, ears to listen to different points of views and different experiences, We can have a heart to cultivate empathy and hands to truly take action and make change. It's important to educate yourself. This is not something that's just for women. Men can be great allies too, and women can be allies for men as well. So we need to educate ourselves and do research and learn about the facts that these types of work environments are still there, not everywhere, but a lot of this stems from the top. And if the senior leadership is promoting a good, inclusive environment that is fair and that does not promote these behaviors, then a lot of the times that will trickle down. It's important to value diversity and allow people to bring their perspectives and backgrounds to the table, be cognizant of inequities, be understanding that people come from different backgrounds. So we need to listen. And sometimes just listening, you'll get to the bottom and the root of the problem. And then you can also offer mentorship and become a confidant for people. What are some of the obstacles that we face, though, when we're trying to advocate for someone and when we try to become an ally? So there's this concept of the bystander effect that I thought was really unique and interesting. This is a cartoon that depicts this, and you can see that there's someone on the ground, and all these people are just walking by. They're not helping this person, and they're all coming up with excuses in their little bubbles. You know, he doesn't need help. He's going to be okay. Someone else is going to do it. Oh, he's just drunk on this one, which I thought was kind of funny. But these are all people walking by and not lending a helping hand. And this is where bystander effect comes in. In 1964, an article was published, and there was a woman, Kitty Gianakos, who actually, unfortunately, was murdered. And she was murdered outside of her building in Queens, I believe. And unfortunately, the reports demonstrated that there were 37 people who were around in the area. They heard something, they heard screams, they saw things, and nobody was willing to stand up and report it. And this bystander effect is the psychological effect that happens where there's a tendency for patients or people or colleagues or whoever it might be to be inactive during situations that are uncomfortable or perceived as high danger situations. And that's due to the presence of other bystanders. So people look around, and if someone's not acting, they don't think they should act, and it turns into this very negative effect where people who typically would offer help or some sort of confidant or some sort of allyship, normally when they were on their own, were not doing this in the group setting. I went back to 1970 and pulled this decision model up, and this basically demonstrates how do we help? How do we decide to do something about something? And at first you have to have an event, then you have to notice it. You have to interpret this as something negative, or that there's a problem, or that there's something urgent or emergent about the situation. You then assume responsibility, and then you have to then know who's the appropriate form of assistance. And then with all of those tasks, you can then finally provide help. What are some barriers? Well, there is this diffusion of responsibility, and this goes hand in hand with the bystander effect, where someone else will just do it. And not always that's the case. So we have to be the people that do it. Sometimes we're scared of being judged in the group settings. What if I do go against what the group thinks and the group mentality? Am I going to be on the reciprocating end of these behaviors? Sometimes you might not think that the situation is all that serious. Maybe you're relying on more overt reactions to the situation. Once again, there's normative influence, and this is that behavior to fit in. And I think we see a lot of the time this is the case in group settings such as residency or medical school. And then some people can try to, assign that there's misfortune where someone was, they did something to deserve that behavior. And that's not, unfortunately, always the case. So what's a bystander versus upstander? Well, a bystander is someone who sees the actions, and an upstander is someone who actually acts. And there are so many different upstanders in history. And I'm sure many people on this call know upstanders who actually see a problem and they drive that change. They try to campaign for others. They try to make the difference and move the needle so that others who are following or who are in their immediate circle and then who are in their outer circle can benefit from this. Bystander/upstander training involves being direct with people. You can approach it by talking directly to someone, delegating the task, distracting away from the situation, or even delaying and trying to talk about it and come up with a solution after that situation is occurring. One thing I want to include is gaslighting. This is something that is very unfortunately common, not just in medicine, but this is a form of psychological manipulation. It's a form of manipulation because it creates doubt in victims who have experienced these negative behaviors, and it makes them question what's really going on. It makes them question their memory. And some examples of statements that are gaslighting statements include, oh, I'm sure he didn't mean any harm by that. That's just the way he is. You're blowing this out of proportion. You need to be less sensitive. Can't you take a joke? There are so many important things to focus on. That's not one of them. And I remember when I was going through my training years, these are things that were said to me. And I remember thinking, oh, yes, maybe they're right. But ultimately, this was just a way to change the narrative to make you question what's really going on. So back to our scenarios. So this was the first one I presented, and this is where Dr. Helen Hand had come in. She's a female surgeon. She had male residents, a female student, and another male medical student, and the patient just automatically assumed that she was not the doctor, but it was the male who was the doctor. And this happens so often, even to myself, even today as an attending surgeon. And it's these types of scenarios that we need to talk to our peers about. When you have male colleagues, you can let them know this happens to you. And if they're in the room with you, they can actually stand as a support and say, no, this is Dr. So-and-so. They are the surgeon. You yourself can stand up for yourself and feel that confidence to know that you worked really hard to get to where you are. And you can say to the patient respectfully, I'm actually the person who is the surgeon. Believe it or not, I am the surgeon. I did your surgery. And then when patients respond inappropriately, like, you're too good looking, are you married, definitely too young to be my surgeon, I try to give patients the benefit of the doubt on this one. A lot of the times people come in and there's no malintent, but it is something that needs to be addressed. And in these situations, you do have to handle this professionally. And you can say, while I appreciate your kind words, we're here to take care of you, and really deflect and distract away from that. Obviously, if that's something that evolves into something more, then that's where you might need to get more involved with and have some other support around. But these are scenarios that at some point, having an interactive discussion on a call, or you going to your peers to talk about, because I'm sure other people are feeling this too. This is another scenario that was sent in. This is Dr. Tanya Trauma, a 33-year-old trauma fellow. She asked the scrub tech for an instrument, and the scrub tech turned and said, I heard you, very nasty, very angrily. And I've seen this before, and I've also had this happen to myself, where if I'm asking for something for whatever reason, there's an attitude from the scrub tech, even though the scrub tech's very good, but would never say that to a male colleague. So Dr. Tanya Trauma says, okay, I didn't realize you heard me since you didn't pass me the instrument. And the scrub tech replies, I only talked to the surgeon. And this actually happened to one of the fellows who I had known. And she said that her senior attending consultant surgeon was in the room, and he actually stepped in at this case and turned to the scrub tech and said, that is disrespectful. She is the surgeon. And that's where male allyship can really come into play. And then lastly, this is Dr. Sandy Shoulder. She's a 29-year-old male. So not Sandy, I guess maybe Sandy, male second-year surgery resident. And a particular male junior attending surgeon made it obvious that he doesn't like this person. He was rude in front of him, making snide remarks and comments. And during the case, the junior asked a question about the surgery, and the attending yelled at him, cursed at him, was completely inappropriate to him. And then after the procedure, people heard the attending physician speaking poorly of this resident. And so these are situations that are truly sent in, and you can see there's a power dynamic. And unfortunately, it's hard for that junior person to go up to that senior attending and say, this is inappropriate behavior. But in these situations, it's important to be able to look at hierarchy and say, okay, is there a senior resident that can be an ally? Is there another faculty member that can be an ally? Maybe someone in the room who heard this going on. It could be you listening in on this, and it's not your resident, but you hear this going on. You as the senior person can help that junior person and pull them aside and say, hey, are you okay? Is everything going all right? Is there anything I can do to support you? And so these are all things that are very commonplace. They're not all overt as far as abuse and harassment, but they're things that can really diminish the quality of life. And so I know we're running out of time soon, so I'm going to just close up with a few last slides, some intervention summaries. Be an upstander, listen to your colleagues, keep your eyes and ears open, offer mentorship. This was something that I wanted to include. This is from one of my slides when I gave a grand rounds at Yale. after I had talked about some of my own personal experiences on this matter. And one of the things I realized that you can change your view of pain, and pain can ultimately become power if you give it purpose. And so we all go through various different adversities and obstacles in our life. And it's the way that we react to it. It's a way that we say we're not going to give up because maybe we don't fit the mold of orthopedic surgery, or maybe we don't fit into this hospital institution. But if you're true to yourself and you work really, really hard, sometimes you can use that pain and put it from a negative energy and make it into a positive one so that you create power, so you can persevere, you can overcome, you can be willing to accept things you can't change, and then also evolve and become more resilient. And so last few pearls and lessons through my work with Speak Up Ortho and Physician Just Equity, and also my own personal experiences, is that we actually all have the power to make a difference, big or small. It's really important to also establish yourself within the field so that you can gain respect in the fields. And at that point, you can then start even moving the needle further to make change. You need to find people who are your allies. Mentorship's bi-directional. So having mentors, mentees, they can teach you a lot just as you can teach them. And it's okay if everyone doesn't like you. And that was hard for me because I was a people pleaser and I still try to be, but it's okay because standing up for yourself and others are going to, you might have some backlash, but if you know you're doing the right thing, you will always be able to go to sleep at night comfortably. And once again, it's okay to say no to things. So thank you so much. I hope that this topic is something that now challenges people to talk about it more and know that there is a safe space. And there are so many organizations like this one and this webinar series that are promoting advocacy and allyship. And I commend this entire group for inviting me and for having me talk about this very difficult talk. But it's an honor to be here. So thank you.
Well, that was excellent. I can only say that we were all just enthralled, and was, kind of a lot of things running through my mind. There's just one thing that I want to ask all the girls. Claudia already got her hand up. How many of us, some of the things that she's spoken about, honestly, how many of us have faced at least something or the other, like what Arianna spoke about in our careers? So you can really see that almost all of us have faced some sort of, hostile behavior at a point. So with that, I want to set the ball rolling and ask Arianna, what should be our, first strategy? I mean, I think I look at it this way, that if you have a very heightened threat perception mechanism, because you're really, that you are going to be swimming upstream, it tends to make you a bit oversensitive sometimes about even casual comments. So what should be our mindset, and how should we handle a first reaction to a hostile situation?
Yeah, so, this is a great question. And obviously, it will be a little bit dependent on what the situation is, because there are some things that are overt in nature and there's just no tolerance, and there's no one can question, if someone says something sexually explicit or someone touches you inappropriately or anything like that, we know that there's no ifs or buts about it. We know this is wrong and something needs to be escalated. But there is that gray zone where sometimes it's not, the intent. I think the biggest thing is focusing on the intent of the behavior. I think that's important to know, where is this coming from? Because number one, when you're training someone or you're in an environment with patients, the patient actually comes first. So their patient care comes first. So if there's something that's going on and maybe that resident is going to cause harm for that patient by doing something, and you have to yell to get them to stop or get them, obviously no one wants to yell, but there are things that could happen in high stress environments that don't necessarily indicate that this is an abuse of power. So I think going into training and your career and having that thought process of giving everyone the benefit of the doubt initially, knowing that this should not be coming from a place of someone trying to degrade or demoralize you, and having that as your initial just like perception before you knee-jerk response that this person was doing something intentionally to do harm toward you. Number two, I think that we are evolving. The fact that we're having these discussions, there is more and more awareness. There's more of us women in orthopedics. But once again, it's important for people to find their allies, because if something does happen, you can go to that ally or a colleague or someone who you trust and reflect on that situation before doing any type of reporting or anything, to say, you know what, this happened to me. This person said this to me. Am I being sensitive? Is it something that I should ask or talk to this person about? And I always believe in trying to work through it at the individual level first. So if someone says something to you and you're comfortable enough to say, sometimes just if someone said something inappropriate, one of the things that I was taught was just ask them to repeat it again and just say, what did you say? Can I hear that again? And sometimes people will take a step back and be like, oh, and they won't even realize what they said coming out, and it lets them reflect, and then they don't necessarily do that again. And so just having that as your first perception that not everyone's out to do harm. I would say majority of people in our profession want you to do well, want to help raise you up, want to include you in this environment, and want you to be colleagues and feel comfortable. It's the small subset that can make it the problem. And so I think also realizing that a lot of the behaviors stem from the top. So we as surgeons, when we're in the OR, that's our ship to drive, or I guess drive, yes. So, that is something that we have that ability to create the environment so that if there is something that happens in that group setting where someone's saying something inappropriate, that's not going to be tolerated. But I think before escalating anything, just coming in from a very positive perspective, knowing that people aren't out to hurt you typically. The problem is usually when it's a repeat pattern of behaviors, not just a one-time, one-off incident. And then talking through with an ally to get a better perception and maybe get some support to mediate the situation if it is something that needs to be approached of that person. I think in those situations, these are more common, and just simple discussions can go a long way, rather than creating this massive problem where you're escalating it so early, and kind of having that knee-jerk response by being a little bit too sensitive.
Yep, that's great. We'll let Claudia ask her question.
Oh, no, thank you. It was actually I was just clapping, just saying, no, thank you. But no, I can ask a question actually, because, one thing that happens is that male typically tend to have this mateship, right? Like they can group well together, and they can, reinforce together each other. And they, and often as women, we are, isolated, or, we're not part of the, of that mateship, the change room, banter, or, go out and get a beer together or something like this. So when something happens, then we still tend to be quite isolated, and it's hard to have that kind of like that conversation. And then you end up being kind of like the whistleblower, and then everything really escalates. So what would be your recommendation on, when you see what happens, in those circumstances where you really have that feeling of, it's not necessarily a bullying or harassment, but it's that isolation that really puts you almost like, the little child in the in the schoolyard that is not included. What can you do?
And that's so common, unfortunately. It really is, especially if, it's amazing that it's wonderful to see more women getting involved in orthopedics, and the numbers are going up, but they're still very, very, very small still. So that does tend to happen to women more than men, although this isolation can happen to anybody who just feels like they're not part of the group for whatever reason. So I think at the resident level or the trainee level, it's important if they can find someone within that group that can be an ally to them, where they are comfortable bringing it to the attention of one person in that group. A lot of the times, people don't even realize. And so if they have one ally or one person they're comfortable speaking with, that person can bring them on board them a little bit, so that they bring them into the social setting, the social circle, are more cognizant that, oh, yeah, we did go out for that drink and didn't invite her, or just like knowing that that's the problem. Number two, I think also, if that person can find some mentorship support within the program. So if there's another female faculty member that they can turn to, or even just any faculty member to talk to get advice on, that faculty member can also be the mediator. I think a lot of people turn outside of their own program to groups like this, where even us in a separate institution can be that support when someone feels isolated. I tell some of my residents, I usually will actually, with my own group of residents, I invite them out, whoever's on foot and ankle service, men and women, I invite them in a small group every so often out for an outing with me. And it's all people who've been on the service. So if you've been on that service, men, women, different levels, just to start integrating people in, so that maybe that one person who feels isolated now is invited to something that's part of the group. And I witnessed that behavior. And then lastly, I do think that ultimately having groups like this established can provide a role for that person. And I tell them that it's like high school sometimes. You watch all those rom-com movies where someone gets, they're not cool, and then you have the cool group, and then they move on, and then you look back and the cool group turns into, this is a finite period for these trainees. And the most important thing for them is to become the best surgeon possible, and not to let this deter them from being their best. But it is like high school a little bit, where 5-year-olds get pushed around on the playground sometimes, which we don't like seeing. But it's something where this is going to also help them grow and develop confidence. And I think just being that support, whether you're in the institution or outside of it, can go a long way for that individual. They'll find their home in some other place that maybe is not that group, and then they'll look back and say, you know what, I'm laughing now.
Anyone else wants to have some queries solved? I noticed that Onder and Arif are still around when they had promised just to, kind of give us their good wishes and go. So are there any questions from you all?
It's so interesting, Rajutha, to listen to such an enlightening talk. Things that we never noticed, and now we hear from colleagues. It's very enlightening. Thank you, Dr. Arianna, for such a wonderful talk.
Thank you very much.
Yeah, thank you.
I just have this one, kind of thing that I want to take the opportunity to point out, that it's not really a microaggression or anything, but it's just that something we are not used to in conferences, and which we noticed happened is, very often now that there are more and more women stepping in, that the height of the podium, or even the way the computer is placed, is usually catered to a standard male height. So can we kind of, in APOA, take the initiative and make sure that from APOA canes onwards, we either have 2 podiums, or we have a transparent one with an adjustable sort of a thing, that would really be so much more welcoming for a lot of us. Saraswati?
Yeah, I think we can always talk about it. We can, there's something, a very little gesture that we should show.
Yes, I think it will be her. Saraswati, any questions from your side? You remember the situations that we've handled in voice. Saraswati is one of my very, very strong supporters in voice. So
no, I I think voice was ma'am's Dr. Rujita's dream, and then now we are 500 plus members in voice, and it is very heartening to see that these topics are being discussed. Small examples of these microaggression. Sometimes the word you used as normalcy. We tend to be, we accept few behaviors because we want to be part of that group. So, though we know that this behavior is not good, maybe, as you said, we kind of, downplay ourselves, thinking that maybe, okay, this behavior I can live with, I can adjust. But sometimes even the intentions are not right. You know that something you need to speak up, but you don't. But these days, because of the group that we have, it's quite an active group. There are girls who are able to reach us, reach Dr. Rujita directly, and we are able to help them out. Though we don't have a big forum like this, but then a small group which started about a few years back, it has become a very good group, and we are able to help each other out. we also have this POSH committees, prevention of sexual harassment at workplace. All the hospitals are supposed to have this committee, all the working places in India. So where again this kind of aggression which is faced by women, you can go up to, it's not just for the doctors, even for other women employee can go up and represent their issues with the committee. So things are happening in a positive way. It's very good to see that we're able to have a talk like this, and then we're able to understand that sometimes when we doubt ourselves, or am I overreacting, and how to go about it. Just the fact that what did you say, just asking that question, which is very important. And as you said, 90% of the times there is no response, and that maybe you have answered, and that is cutting at the nip or whatever. So that way it is. Yeah, very happy with the talk.
There's just one question which I think we've received from our viewers. A very interesting one, that too. It says, Arianna, what would be a strategy if you feel as a woman boss that the men who are working below you, they have a problem taking you in that position as a boss? What would be your strategy?
It's a tough one. That's a great question, because unfortunately this can happen to whether you're the boss or you're just even at the same level as some of the male colleagues, but being the boss in particular is it's difficult. I think that, I guess it depends on what the behaviors of the junior people are portraying and doing. But I think that there comes a point where you as the boss have to have confidence in yourself to know that you're probably not going to be liked by some of these people that are underneath you in general. Because in order for you to be respected, sometimes you have to do some hard things that people aren't going to necessarily agree with you. I've also found, and this took me a while to develop this confidence, but I found that people who are bullies or people who act that way disrespectfully, a lot of the times they're actually cowards at baseline because they're acting that way. You can see that they're not strong individuals, because a strong leader wouldn't act that way. And actually just like going directly at them and being direct with them can go a long way. Calling out the behavior directly. And if it's something that's unprofessional, I now flat out just say, what you just said was incredibly unprofessional to me. Is there a reason why, or why are you so angry? Why are you acting this way towards me? I think that as a boss, you might have to have individual meetings with people to try to get the sense of where the disconnect is. Who's maybe the ringleader in the group that is causing there to be maybe some disrespect amongst the peers, if it is more than one individual. And then sitting down in a group setting. And then, I always believe that in order to really stop negative behaviors, there has to be some form of consequence. Someone needs to be held accountable. So if the people underneath you think that they can get away with saying things, doing things, and have no fear that they're, because, oh, she's not going to do anything about it, she doesn't want to have conflict, she just wants to make sure everyone's okay. Sometimes implementing rules, like very objective, it has to be all objective, keeping your cool in conversations, not getting emotional, not getting, keeping everything objective, documenting behaviors as well is really important. And I always recommend doing this where you document it, send it in an email, because then it's time stamped. That's for legal purposes in general, but just for your own records. These are ways of showing patterns of behavior so that if someone keeps acting up or acting inappropriate underneath you, you then have an entire file to say, this is why we can't have you on board. This is why your privileges are going to be, revoked for a short period of time. This is whatever that looks like, as far as the severity. But I do think, number one, it's first just having that confidence to say you're the boss. Like, you got that job for a reason, and it's because you deserve it, and you worked really hard to be there, and people need to respect that. And so I think coming in with that mindset and then figuring out an objective way to document what has been going on, giving the opportunity to those individuals to speak up for themselves and try to get to the bottom of it, and giving them that one opportunity to understand why the behavior is happening, and then going from there.
Well, I think, thank you. We could go on perhaps with this topic all day or all night, because there's so much that each of us has to share. But in the interest of time, we should now move on to the panel discussion, and we'd request you to stay on if it's possible. It's been really great having you here, and I'll also take this opportunity to invite you to write a review article if you can for the Journal of Indian Orthopaedics. I'm the guest editor this year for a scientific issue, journal issue focused only for women in ortho. So I'll send you the formal invite, but I think this would be one of the topics that we should be addressing in that journal issue, or even clinical
Absolutely.
work.
Thank
And
you.
all of you all are invited to submit to that. So we now move on to another awaited panel discussion. And I'd like our lovely treasurer, Emel, and who's going to really take this forward from me to introduce both our moderators, and then I can introduce the panelists.
Thank you, Rujita. Hi, everyone. It's my great pleasure to welcome you all to this special webinar in celebration of International Women's Day, bringing together incredible women orthopedic specialists from across all the world. Today, we will be discussing a critical topic that resonates deeply within our field, orthopedic subspecialties for women, how to decide on and navigate challenges. These discussions are not only timely, but also essential in shaping a more inclusive and supportive future for women in orthopedics. We are honored to have a distinguished panel of speakers joining us from 4 different countries, each bringing valuable insights and experiences. Guiding our conversation today, we will be our esteemed moderators, Sema and Melanie, who will ensure an engaging and thought-provoking discussion. I encourage all of you to actively participate, share your perspectives, and take full advantage of this opportunity to learn more one another. I now want to invite Sema Ertan Birsel. She's currently working at the Orthopaedic Academy of Paediatric Orthopaedics and Acıbadem University Atakent Hospital, and she's mainly interested in pediatric orthopedics and trauma. She's a board certified surgeon. She's graduated from Istanbul University, Cerrahpaşa Medical Faculty, and she has taken her residency training at the same hospital. She also had an observership with Professor Miller at DuPont Children's Hospital. And she's a member of APOA, EPOS, TOTBIT, and Turkish Pediatric Orthopedic Association. And our other moderator is Melanie Amarasooriya, and she's an upper limb surgeon, practicing orthopedic surgeon, completed her training with fellowships in UK and Australia, and also a PhD in wrist biomechanics as an orthopedic surgeon, and also affiliated to Flinders University, South Australia. She is a senior lecturer in Medical Technology, University of Moratuwa, Sri Lanka, and she is the first board-certified woman orthopedic surgeon in Sri Lanka. She's also Asia Pacific Wrist Traveling Fellow and member of International Federation of Societies for Surgery of Hand Traveling Fellow, and has Centenary Award South Australian University Woman. Once again, welcome to this important event. Let's make this meaningful and impactful session.
I will now quickly introduce our panelists. We have Dr. Claudia Di Bella from Australia, a very, very understated person. Although she is the recipient of many, many awards, she specifically requested that I only introduce her as Associate Professor of Surgery at the University of Melbourne, a specialist in arthroplasty and orthopedic oncology, and the head of the Sarcoma unit in Melbourne. Then we have Ramona Reyes-Diyco. She's done her clinical fellowship in spine surgery at the National University Hospital in Singapore and has been practicing as an orthopedic spine surgeon for the past 10 years with a special interest in cervical and degenerative spine conditions. She's currently based in Manila, Philippines. And we have Saraswati Viswanathan, who's graduated from Kasturba Medical College, Manipal, and then pediatric orthopedic training at the Kanchi Kamakoti Trust, Chennai. I hope I've got that right, Saras. She's been like a gifted daughter to me by the universe. She's the backbone of voice for me for all the endeavors that I have done in India, and she's taken it forward because of her commitment. And she's currently practicing in Bangalore as a pediatric orthopedic and trauma surgeon. And since we have the lovely and ever-smiling Tunku Sara Ahmed from Malaysia, I would really love if she can introduce Rifa Atiqua.
Thank you very much, Rajita. Happy Women's Day. I'm happy to be a part of this WAVES APOA program. It's my pleasure to introduce Rifa. Rifa Aquidah Binti Subhan. She's graduated as an orthopedic surgeon in 2014, and she has been working in two of the busiest government hospitals in Malaysia. As a master's student, her research won her the best master's research in the whole of Malaysia. And when that was published, it became one of the best translational research publications in Malaysia. It was regarding stem cells and the spine. She teaches undergraduates in one or two universities, and she's also done a couple of fellowships, notably in arthroplasty. She lists her special interests as trauma surgery and pediatric surgery and hip and knee joint replacement. She has a large number of courses that she has done, and she's active in our Orthopaedic Association activities and on several committees for courses and conferences. The thing is that she actually has not herself signed up for any subspecialty, so it'll be very interesting to hear her view as someone who has yet to choose, or maybe she prefers to remain as a generalist, and maybe there's a viewpoint for that as well. So thank you, Rujuta. I think that's my introduction of Rifa.
Okay, then let's begin the panel discussion. Over to Sema and Melanie.
Yes, thank you very much, Rita and Sarah. Happy Women's Day to all, first of all. I would like to start with Dr. Ramona Reyes. I want to ask her, as a spine surgeon, which is a really extremely intense, stressful, and physically demanding field, what are the most demanding aspects of being a spine surgeon as a woman, and how do you navigate these challenges?
Hey, good evening, everybody, and happy Women's Day. Thank you for the question. I think as a spine surgeon, the most demanding thing would be basically that the procedures themselves tend to be quite long. And you have to be very meticulous with planning the procedure itself. A few things, of course, because we do have a bit of radiation, you protect yourself, make sure you do have your lead gowns, goggles, gloves, I guess, for some. But overall, I think the main thing would be having a very good support group, having a good team. So having fellow spine surgeons that you can discuss your cases with very well, having a team to assist you so that it does cut down on time, and as well as providing your patients with better safety in the OR. So yeah, I think those would be the main things for me as a spine surgeon.
Thank you very much. And Melanie, do you want to ask some question to Dr. Reyes?
Yeah, of course. Ramona, I was thinking, as a spine surgeon, how easy was it for you to find training positions like fellowships and further training positions? And how did you navigate that if it was challenging?
I think it was, I was lucky in the sense that I did have very good mentors who directed me in the right direction. They had friends from where they trained before and offered endorsements, which was very helpful. It was more, I think, of the wait, because you do have to send in your, I think, your applications as early as maybe your third year, just so that you get to be accepted in a program by the time that you do graduate. But again, I feel I was very lucky in that sense. It wasn't so much a big issue or a big difficulty for me, because the teachers, the mentors that I had were able to provide good endorsements to the fellow spine surgeons that they had.
Thank you. On the same note, can I just ask, are there any websites or are there any associations that trainees should look up if they're interested in spine surgical fellowships and positions?
I am not too sure about one specific website that would actually give you a list of all of the available, I think, training institutions. I think for the most part, you probably start with where I think you would like to have your training done. If you do have a specific subspecialty that you would like to go into, whether it's cervical or maybe deformity, again, there are particular areas in the region that you might want to go to. For me, I think particularly because the consultants that I did have had more, I think, connections in that sense within the Southeast Asian region. So that made it a little easier for me to look for a training program within my region. But there are other, I think, trainees now that can branch off as far as Australia. We have a lot who actually go and visit Australia, as well as to the US. The US does, however, require US MLEs. So that is, I think, one of the major, I guess, it's not so much a setback, but it is an additional step that they have to finish to get into a training program in the States.
Thank you very much, Ramona. And next, I think I'd like to ask a question from Dr. Rifa, if that's okay. So Dr. Rifa, so you've done a lot of work as a trauma surgeon. My question to you is, have you ever regretted being a generalist? Have you ever felt that, oh my God, I should have done hands or something? So yeah, what are your thoughts on that?
Thank you very much. Yeah, there are days that I do think, should I have done the subspecialty training? But I would like to say that I advocate subspecialty training in this current day and age. But having said that, no, I do not have any regrets not doing my subspecialty training. I think everybody has their role to play. Someone has to do the basic trauma work. Someone has to inspire our young children about the core bread and butter of orthopedics, which is trauma. So I think I always envisioned myself to be a pediatric surgeon, and hand surgery was always a close second love. But at this time, life had its own plans. I had to prioritize my family. So, but to compensate for that, I do a lot of teachings nowadays. On top of my busy work as a general orthopedic surgeon, I do teachings. I do more of hospital admin work. I do more into auditing of the hospital, and I try to busy myself more with social responsibilities, such as my charity work. So no, a quick answer would be no. I do not have any regrets not pursuing a subspecialty training.
Thank you. Sema, do you have any questions as well?
Thank you, Melanie. Just, of course, we are all trauma surgeons beside our subspecialties. And for myself, I like trauma surgeries, I like trauma cases. But if we choose a subspecialty, we are getting away a little from trauma surgeon. But as I want to ask you, what are the most satisfying aspects of choosing trauma as subspecialty? Do you think that just having trauma or emergency cases and treating these cases are enough for satisfying, or do you think another aspects? Do you have another aspects for choosing this trauma as subspecialty and satisfying aspects essentially?
So, doing general trauma work, I liken myself to like the favorite aunt, Aunts, they have that unique position where they can actually borrow their nieces and nephews, and they can have like a blast with their nieces and nephews. And then when they get a bit tired or they get a bit cranky and they get harder to deal with, you just send them back to their parents. So I liken my general trauma work like that. I do have special interests. I I do some trauma, spine surgeries. I do some lumbar and thoracic fixations. I mentored with a pediatric orthopedic surgeon. So I did quite a bit of work in congenital hips. I do CTEVs. I do quite a bit of deformity corrections. Currently, I do a lot more of basic arthroplasty, primary knees and joint surgeries. So I don't think trauma is just trauma per se. I do a little bit of my special interest work. So yeah, keeps me full. And yeah, I'm quite happy doing it. Yeah.
Yeah, thank you very much. So I want to ask a question to Dr. Claudia Di Bella, and she is dealing with sarcoma arthroplasty, and I think it is really difficult part of the orthopedic surgery. Dr. Bella, how do you navigate the emotional challenges such as pressure of patient expectations or versus reality of being a tumor surgeon?
Thank you for the question. Well, I actually find as a tumor surgeon sometimes less pressure than I would have, for example, for high level sports surgeon, for example, because with tumors it's nature, it happened, and you're trying to really salvage what is possible, and so it's the kind of the demands of the patients and the way they actually are really thankful. It really fills my cup often much more than the expectations of sometimes high level athletes that I wouldn't be able to meet. So from that perspective, it really helped me at the beginning of my career, really actually understanding where to put priorities and how to really see and look things in perspective. So I remember often my friends used to tell me, how come you're always happy? How come you're always, so, positive? But, when you look at, how life can change in an instant, it really puts things in perspective. And so I think I'm blessed that is one of the, the things that I love to do. And I think I'm just lucky. And I don't do much trauma, actually, because for me, as Rifa was saying, it's all about, family and making sure that things are, balanced as well as possible. Balance really never exists, but, as well as possible. And so I like to plan. And so with trauma, for me, is always the unplanned. And so I'm, as a choice was just like, arthroplasty, tumor surgery, and, very rarely there is this kind of like emergency. But can I say one thing, just in response to the first question about the fellowships and the training? Of course, not in spine, I don't do spine, but in arthroplasty, there is a very successful now program of women of Asia Pacific Arthroplasty Society. And we sponsor 2 fellows, traveling fellowship around. They go around, with Australia, Malaysia, India. I cannot remember. It's 3 or 4 countries of traveling fellowship, and specifically for women. And we've been sponsoring this for the past few years. So if someone likes arthroplasty, that is something that we are really encouraging. And in the tumor world, with ISOLS, which is the International Society of Limb Salvage, I'm the head of the DEI committee, and we're looking at sponsoring also some fellowship and traveling fellowship, ideally, not only for men, and so to really invite and inspire more women in that. So actually look out, because there is a lot of events in different specialties, and a lot of opportunities in different specialties for learning, for networking, and for really getting the most out of your chosen specialty.
Thank you very much sharing this knowledge for us. It is very appreciated. Melanie, do you want to ask a question?
Yeah, thank you. Yes. As you pointed out, as Sema pointed out, and also Dr. Rifa pointed out, we all start as general trauma surgeons, and we fall in love with trauma, and we do orthopedics, and then we find our own subspecialty or own area of expertise. In that regard, Claudia, how did you become, or why did you become a tumor surgeon? What were the most satisfying aspects that drew you to tumor and arthroplasty surgery?
Yeah, well, I started with tumors actually. Arthroplasty wasn't what at the beginning I started to do, because I trained in Italy at the Rizzoli Institute, which is one of the places where orthopedic oncology really was sort of founded in a way, in a modern way. And yeah, well, it actually, when I was talking about the athletes, I used to be an athlete when I was in a different life, but that's what I thought that I wanted to do. I wanted to be, an orthopedic surgeon looking after athletes. And then for me was the expectations and the kind of the team management that really couldn't match up with nature and with the healing times. And so by chance, I joined the orthopedic oncology group there, and I absolutely fell in love with that specialty, because it was orthopedics, of course, which is what I absolutely love to do, playing with tools. But it's also a different way, because it's that long follow-up. We follow up patients for 8 to 10 years, and you really see them thriving, even after you've seen them, giving them one of the worst news probably of their life, and then you see them thriving, and it's so beautiful because you really create that relationship. So for me, I'm a true woman in this profession. I do love creating relationship with my patients and following them, and getting that real bilateral understanding. And it's something that with orthopedic oncology you can do, because you see them very, very often, and that's probably what really drew me to this specialty. And with arthroplasty, I say what I usually say is, I love a good day of arthroplasty. It's a relaxing day when you just do hips and knees. It's nice and relaxing in the OR. So there's a bit less stress on those things. But yeah, I guess it was a bit of luck and a bit of just faith, I guess, for me.
Thank you. All right, so let me ask Dr. Saraswati, who's a pediatric orthopedic surgeon. So, Dr. Saraswati, what were your reasons, and what were your reasons to choose pediatric orthopedic surgery? And did you find any challenges along the way, or how did you navigate them? Do you want to talk us through your career?
Thank you for this question and this opportunity. I was trained in a place where we had 6-monthly rotation every aspect. We had spine surgery and pediatric orthopedics, hand surgery. So I was really lucky enough to be trained under really good professors in these fields. And what I really liked in pediatric surgery was my professor. I think we always look up to a mentor. And the professor under whom I was trained was really good, the way he used to handle patients. And I realized that I took up orthopedics because of a professor during my graduation days. So you like a subject because somebody teaches you very well the subject. You fall in love with the subject. And also, like Dr. Claudia pointed out, my patients are resilient. When you look at pediatric orthopedics, most of these children, they do well. They are resilient. When you look at them, you get a positivity out of them. So the patient choice, treating children kind of started, I started feeling very good about treating them. So going through all the different subspecialty, I kind of liked pediatric orthopedics because my professors were good, and also the patients, the satisfaction that I was getting out of it was good. The hand surgery was something which was really close to the, I was looking at it, should I become a hand surgeon? But again, the long rehab of the patients. Dr. Melanie, you're doing it, I don't know how, but then each of us have our own choices. So hand surgery was something which was again very close to the pediatric orthopedics. But then I realized that I am more content with pediatric orthopedics, dealing with children. Most of the times when you see children, even with the bad deformities, the smile on their face, they are just oblivious of their deformities, and you are happy to see them, treat them, talk to them. And as Dr. Claudia pointed out, you have a bilateral relationship. You have a relationship with their parents, and then you follow them up till they are about 15, 16. You come to know when they're achieving something in the school. You know, a clubfoot child, they send you a photograph saying that this child got a first prize in a running race. That makes your day, that makes you happy. So just the job satisfaction of doing orthopedics and also seeing these children do well, it just enhances your happiness. So that's the reason. As far as the challenges are concerned, I think I was one of the only resident during those days. We were about 19 postgraduates. I was the only female at that point. But I had allies. If you look at it, I had people to, you know, go back to. I had my colleagues who were really good. I had my junior level professors who were, you know, approachable. So that did make a lot of difference. And few ups and downs were there, but I think it was all for good.
Thank you. Sema, do you have any questions?
Yeah, as a pediatric orthopedic surgeon myself also, I want to ask her, Dr. Saraswati, you know, there is a common site about pediatric orthopedic surgery that women do it easier than the other subspecialties. Women can do it easier because of the small size children, and they think that you need less power or less physical demand. But do you agree that, you know, pediatric orthopedic surgery is a huge pool of knowledge? You have to work harder than the other subspecialties because there are too many diseases, syndromes, and the other things. But it is really well presented in the worldwide, the pediatric orthopedic surgery by women. Do you think that the mentorship is really important, of course, but it is easier, so the woman choose it? Do you think that? Do you agree or not?
Me and Dr. Rujita keep talking about it. She says that yes, we are quite a lot of pediatric orthopedic women surgeons in India. Now we have other girls who are into various other subspecialties. Initially, maybe it was kind of, you know, your mentors did want you to take up hand or pediatric orthopedics, but most of us took it by choice. It was not forced upon us, if you look at it. And I don't think it was mainly because of the size or whatever it is. As you said, it is even more complex than a plasty. I mean, I'm not the right person to talk about it, but yes, it is complex. You have more variety of cases, you have more syndromes, you have a lot of data to deal with when you're dealing with children. But having said that, the choice is purely, most of the people, it is based on what they like. And pediatric orthopedics is something which in India, you have a lot of cases. You know, even in patients are many in numbers because of the population itself. And most of the places where we get trained, we do see a lot of children with, you know, even with club feet, you have a lot of numbers, DDH, you have numbers. So you do get interested looking at the number of patients and, you know, doing good for them. So that is also something which drives you to probably take up this field. And another thing that you said is, you know, sometimes you do feel that there are women who don't want to take other, fields. There is, for example, spine, where Dr. Ramona has taken. But then here there are women who feel that the work-life balance may get affected. But in India now, we have good spine fellowships. There are a lot of women who are mentors, who are helping these girls who want to take up spine, helping them and showing them the way how it can be managed. So having good mentors and in the same field, and having mentors, female mentors in these fields, are also changing the perspective how the girls are taking up.
Thank you very much.
Sema and Melanie, if you allow me, I just want to add on to what Saras is saying. Definitely, I think the perception still in society at large is that pediatric orthopedics is good for a woman. I think what people really need to realize, or the girls especially when they're choosing a career ahead, is that you need to figure out the aptitude that you have in the 3 years of training. Orthopedics is now such an advanced field that the 3 years that you're doing in your degree training is just a window. It's going to show you the different specialties, and there is so much happening ahead The flavor of the month currently in India is all sports and scopy. I think we have a special wing, which is Indian women in arthroscopy, and they're even doing workshops by themselves. But I'm seeing arthroplasty women coming up. In fact, the 9 o'clock webinar that I'm doing is all with women in arthroplasty in India. But pediatric orthopedics it's not going to be all about less power. If you're dealing with an SCFE, if you're dealing with adolescent fractures, you're still going to require as much power. So just be ready to embrace a huge spectrum of things which will actually test your mettle in terms of knowledge, decision making. And that was one of the things that actually made me fascinated with pediatric orthopedics, that you're putting things right, but at the same time, you have to have an eye on the future as to what's going to happen in the long term. Yeah, Claudia, you can add in something.
Yeah, no, thank you, Rujita, because I feel that, as an arthroplasty and a sarcoma surgeon, typically that was a typical question, like, oh, how do you do it? This is like so heavy, so difficult. The concept of heaviness or difficulty of weight or how powerful you need to be, I think we really need to demystify this concept for everybody, not just for women, really. There are a lot of men that are not necessarily 6 foot tall, right? And it's our specialty. It's all about technique. You need to be really good at the indication of surgery, if you're talking about just surgery, indication of the surgery and how you perform that surgery. So it's the technique. If you need to force something, means that something is not quite right. And this is one of the things that I always teach my the juniors. I do DA, so anterior approach to the hip, which typically, high risk of complications, but it's because we tend to, think that we need to use the force. And no matter what specialty, including when I do a hemipelvectomy, I do not use force. It is about knowing what you're doing and doing it well. So no matter the specialty, there is no force required.
Yeah, I just want to point out this because in my country and as I see the whole worldwide, the women are driving to pushing to the pediatric orthopedic surgery because they are advised that it is easier than you because children are small, but it is not true. For the whole orthopedic subspecialties, you are right. It is a technical aspect, important one. You don't need to be too strong, too big, anything else. If you know what you do, the technical aspects, indications, treatments, you can do it, all the subspecialties. But unfortunately, because of this side, I think most of the women in orthopedic surgery are common in the pediatric orthopedic surgery fields because of this, but it must change. I think the mentorshipness is most important in this field. The women mentors increasing, and I think the subspecialties will get more women residents, more women surgeons, I think, in the future. This is my opinion.
Want a quick perspective from Arianna, since she's the only one representing sports and scopy today? Oh, sorry, we have Erica also, but who prefers to be in the background.
Oh, sure. Well, first off, I just want to say that you picked an incredible panel because now I'm questioning every decision I ever made because all of these specialties sound so awesome. And everyone, I think the biggest thing, the biggest take home is to find what you're most passionate about because that's how you're going to excel in it. And everybody on this panel, just the way they're speaking about their experiences and what they get to do, you can tell that they're truly driven and passionate, and that's going to translate into better patient care. So it's really fun to see. And I'm always like, oh, we need more women in foot and ankle. So I'm still trying to reel people into foot and ankle. And as far as for foot and ankle, one of the things to consider for those who are potentially interested in listening in is that one of the things I love about it is that there's so much variety in it. So, you know, my day-to-day, I do focus more on sports. I take care of a lot of our athletes, and I love that that Claudia had mentioned taking care of the athletes. Sometimes it is the mental component of it is a whole, you know, field on its own. But with regards to the specialty, you know, there's a day where I'll be doing an ankle scope, or I'll then fix a foot trauma fracture, do an ankle replacement, do a tendon transfer, deformity correction. So the one thing about foot and ankles, there's so much variability, because I think there's been a lot of research in other specialties and not as much in foot and ankle. There's so much opportunity to really tweak different procedures. There's new opportunities with our minimally invasive approaches now with technology and techniques and the scope procedures, that I think it's just an exciting field, because there's a lot that we can still do for it. And there's a lot of different paths you can take, whereas, you know, I have more of a sports focus, but I still can do the bread and butter. I also like staying away from anything serious like an aorta or an pelvis, or, you know, a lot of the times my worst things that go wrong with toes. And so, I mean, it's also that type of mentality too. But ankle's a great field. And one of the things that a subspecialty that I just want to reiterate that was touched on earlier with some of the panelists is that no matter what you go into, it doesn't matter your size, your shape, your strength, you know, you're going to be able to do it. There is so much more focus now in industry on making things more ergonomically friendly for women. You know, now they're starting to actually, whereas everything was made for the male hand, as far as size of instruments and different types of things that you'll be using equipment wise, now there's focus on, okay, what if there's something for a smaller hand? Like, what happens if I can't reach this? How should I be standing? How do we, you know, I recently just had some neck stuff going on, and I'm like, okay, ergonomically, can I sit? Can I bring the head back? All these things are now starting to be talked about more and more in our field of orthopedics. And so the size thing should never deter anyone, because we are, and maybe people on the call will be part of that change in developing some of those instruments and tools to make it more ergonomically friendly for all of us, so that we don't have, you know, carpal tunnel and need to go to each other to get fixed up down the road.
Well, I think this has been a great discussion, and we have lots that we could always meet over again and discuss. So let's take this as a good start, and I hope we continue such programs in future. I'd like Emel to propose a vote of thanks to everybody.
Thanks, Rujita. Hi, everyone again. It's an absolute honor for me to extend our heartfelt gratitude at the conclusion of this insightful and inspiring webinar. On the special occasion of International Women's Day, we have had the privilege of hearing from remarkable women in orthopedics across the Asia-Pacific region and all around the world. The discussions on dealing with abuse in the workplace and navigating subspecialties as women in orthopedic have shed light on crucial challenges and provided valuable guidance for many of us. Thank you to our esteemed speakers for sharing their expertise, experiences, and words of encouragement. A special thanks to organizers and everyone behind the scenes who made this event possible. Your dedication ensures that conversations like these continue to empower and uplift women in our field. To all participants, your engagement and enthusiasm prove that together we can create a more inclusive and supportive future for women in orthopedics. Let's take the insights from today and use them to drive positive change in our workplaces and communities. Thank you once again, and wishing you all continued success in your career. We look forward to welcoming you to APOA Cairns Congress and would be delighted to have your participation. Thank you.
And thank you to you, Emel, for being there all through, threading everybody together. Erica for being our tech support. She's our Secretary General and a very accomplished sports surgeon herself. Dr. Arif Khan and Dr. Onda Aydingyos from the APOA Exco, and Poonam and OrthoTV for always giving us such a worldwide platform to host this. And last but not the least, APOA Waves for bringing us all together, and hope that the waves go on surfing and create a tsunami. Adios.